Okay, I think out of respect for everybody who has joined on time, let us start. So, I would first like to introduce myself for people who don't know me. My name is Sadaf Lyons. I'm the Director of Collaborative Surveillance Workforce and Health Emergencies at IANPHI. And I welcome you on behalf of IANPHI to this webinar. We are in particular today going to be talking about the work that we have initiated under the umbrella of the role of National Public Health Institutes in health emergencies. So just a couple of housekeeping rules. First of all, we would appreciate it if you kept your audio on mute to create minimum disturbance in terms of the presentations and the questions. Secondly, as we move through the presentations, if there's a question that you would like to ask, please put it in the chat box, which we will monitor. If there are specific questions to specific speakers, I would appreciate it if you would just jot down the person's name so that we can direct the question to that speaker. And I hope that we will have a session which will deal with questions and answers after the panel session. So that will also provide opportunity to ask additional questions. So I would just like to start by going through the agenda. Raphael, if we could have the next slide, please. Okay, so the agenda for this session is I will provide a quick overview and background of this work. Then we will move on to Professor Andrew Lee, who will be talking a bit about the background and objectives of the project that was just recently concluded. The findings of the survey and interviews that was conducted will be provided by Janine from who's part of our team from the National Institute for Communicable Diseases of South Africa, followed by a presentation by Rosita, who's the program manager for IANPHI, and she will be covering the second part of this piece of work. And then I will come back in just to give you an overview of the so what are the next steps really in terms of the recommendations and the phase 2 piece of work that we will just be initiating in the next couple of weeks. We will then move on to our two guest speakers, which is Dr. Tamina Shirin from Bangladesh's Institute of Epidemiology, Disease Control and Research, and Professor Amar Ikram, who is the Vice President of IANPHI. And they will just provide their overview and their reflections on this work and what does it mean for their respective countries and for IANPHI as an association. So that will lead us very neatly into the question and answer session, and I will just finish off with some concluding remarks. So that's the agenda for today. So just to give you context around this, Raphael, you can take down this slide, please. That's okay. So just to give you a bit of context around this work, this was initiated by an award that we received from the Gates Foundation, which is related to IANPHI's partnership with the WHO Global Health Emergency Corps. And as a partner, we have been working with the WHO GHEC Secretariat in co-designing and co-developing a framework that looks at the key domains under the health emergency system. That in particular is looking at rapid response systems, surge mechanisms, the public health workforce that is required within a health emergency, and underpinning that is how important connected leaderships are in terms of interaction, acting as levers and enablers for national public health institutes to be operational during a health emergency. Obviously, taking those domains of the Global Health Emergency Corps from our perspective, IANPHI as an association, is that how do you apply them on a national level? And what does this mean in terms of the roles and mandates of national public health institutes? Not only when a health emergency happens, but actually what does the architecture need in terms of normal practice upon which you can then scale up during a health emergency? So those were the kind of questions that we had in terms of developing this National Health Emergency Corps and the role of NPHIs. So, with the grant funding that we received, we decided to undertake a survey with our NPHI members and also conduct some interviews with some NPHI leaders to understand a bit better around how did this apply at the moment to NPHI and what kind of constraints and gaps and challenges could we see within that. At this point, I really do want to give some thanks and recognition for the core team who worked on this. We had a really fantastic team from Public Health Agency Canada, from UK Health Security Agency, from South Africa, helping us with this, and also the IANPHI core team that you see here today, who will be doing a presentation, ably supported by Professor Andrew Lee as the technical lead. So with that, I would like to just hand over to Andrew, who will give a bit more context and just talk a little bit about the methodology and background. Over to you, Andrew.
Thank you very much. Hello, everyone. Lovely to be with you again and to see quite a lot of familiar names and faces. Let me take you through the methodology for the work that we've done. Now, this was a mixed method study with two components. One was a survey of the National Public Health Institute membership of IANPHI, and the second were key informant interviews with a targeted group of NPHIs. Next slide, please. As Sadaf has intimated to you, all of this builds very much on the Global Health Emergency Core framework that has been maturing in its development over the last few years. You will remember during the pandemic that we encountered a lot of difficulties, a lot of challenges with mobilizing a response, both at the national, subnational axis as well as abroad. And many of these challenges remain today. The WHO GHAC team, together with collaborators from around the world, including IANPHI, we've been trying to see how we can help better operationalize this model, this framework, so to speak. And it's all about trying to enhance that health emergency prevention, preparedness, response, and resilience work that is a core function of all our NPHIs. The vision, as you know, next slide, please, is to build that connected health emergency leaders network worldwide to enhance and strengthen our surge capacities. And again, bear in mind the duality of that axis, both from the national to subnational axis as well as to the international, and what we can do to strengthen our public health emergency workforce around the world. Easier said than done. And I think Tedros summed it up really, really well. There is no global health security without local and national health security. So much of this work is in pursuit of that goal. Next slide, please. As I said, there are two components to this study. And the focus really was to try and understand what was the role of national public health institutions in public health emergencies, and what were the functions that we were responsible for. What's the remit for our NPHIs? And the second bit was about the extent to which we are involved in leading those agendas, okay, across the various GHAC domains. The purpose to gather all of this information was so that we as an IANPHI body and as a global community would have a better understanding of the current landscape of where we are now. And hopefully that would help inform what we can do to strengthen our agency roles and our ability to mount effective and rapid surge responses to emergencies. Okay, we are using some of this information to guide ongoing work, as Sadaf will tell you a little bit later, which will hopefully form resources that IANPHI can provide to its membership to generate position papers and publications to help build that evidence base and to identify recommendations to support further GHAC development, which we are feeding in to the WHO GHAC team as well. Next slide, please. So the survey, this was done between October last year and March of this year. Many thanks to all the NPHIs who took part. It's a massive piece of work, I know, and quite laborious. We had something like over 59 questions that your colleagues had to compile for us. And the outputs of our work is only as good as the inputs and support that we have received from NPHIs around the world. So many thanks for that. We did it in 4 languages: English, French, Portuguese, and Spanish, using an online select survey questionnaire platform. And this was sent to focal points in all the NPHIs that were part of the IANPHI membership. Okay. And the questions that we were asking was there to try and characterize the roles, size, response, the demography of the NPHIs involved, something about their mandates and authority, and an understanding of the governance of those responses and decision-making processes in health emergencies. We were trying to understand what the public health emergency workforce needs were, the surge capacity and rapid response mechanisms as well, and an idea of what the nature of connected leadership means in health emergencies for NPHIs. And this information, as you'll see in the slides to come with Janine, was looked at through different lenses in terms of WHO regions, World Bank income groups, as well as NPHI size. Next slide, please. The key informant interviews, as I said, this was targeted at a select group of NPHIs. We purposely selected a range here. We're wanting to get both high income and low income NPHIs, as well as from as many WHO regions of the world as possible, to just try and get a sense that was hopefully generalizable across the patch. Yeah. And these interviews were carried out between January and February. And again, many thanks to all the NPHIs who took part in this as well. Okay, a lot of the questionnaires that we used for the survey and the topic guides, these were pre-tested, and we do give thanks to colleagues from GFEP who were involved in this, from GORN, as well as Zambia, who participated in helping to validate the questionnaires that we used before they were deployed. Okay, right. Enough from me. The real story is from my colleagues to come, Janine and Rosita. So let me hand on first to Janine. Over to you, Janine, please.
Good day, everyone. So thank you so much for setting the stage, Andrew. So as Andrew mentioned, what I'm just going to do today is to take all of those 59 survey questions and I'm going to try and summarize it for you, just highlighting the most important things and setting the stage for Rosita and Sadav and our presenters to come as well. So Andrew already shared with us what aim and objectives were. So what I'm going to do is I am going to be using our GHIC domains to really summarize all of these results. So if we look at the demographics of our respondents, we had a response rate of 47%. And again, thank you very much for everyone who did respond. We had representation from all of the World Bank regions, WHO regions, as well as the all income groups. We did have more respondents from Euro and Afro, and also as well as from the high income and lower middle income countries. Then if we have a look at our participation rate by the demographic of IANPHI membership, it is, sorry, I'm just trying to stop my video as well. So just to save some internet. So looking at our IANPHI representation, the highest representation were from IMRO, from our Eastern Mediterranean region, followed by WIPRO, and again from our high-income countries and the lower middle-income countries. Most of the participants were actually NPHIs. They were national members, 86% of them. And the majority of them had a national remit with teams operating at the national level. We did see some, 29%, operating at an international level, but this was mostly focused in our high-income countries and in AMRO. NPHIs are actually quite small. The majority had less of 55%, had less than 500 employees, and the majority of NPHIs have been established more than 10 years ago. Looking at the roles of the NPHIs in the health emergencies, 85% of NPHIs had a legally mandated role in the management of public health emergencies. If we now have a quick look at involvement of the NPHIs in the public health functions, the most common functions that they were involved in were emergency or preparedness planning. So all of the NPHIs were involved in this, surveillance capability, and communicating information to government and other national agencies. NPHIs were the lead agency for specialist lab or scientific capability. Again, surveillance capability, 65% of the NPHIs, and then also seeing the mechanisms and analytic capability to carry out the risk assessment coming up as well. The NPHIs did not have a lot of involvement in actually mounting a public health response by deploying field level teams in the disaster recovery planning and in post disaster debriefing and lessons learned. The type of the hazards that the NPHIs are involved in, most common ones were infectious diseases, environmental hazards, as well as biological hazards. But we also see some involvement in the NCD space, in our non-communicable diseases. NPHIs were less commonly involved in animal health, health equity, environmental quality issues, climate change, as well as water and sanitation challenges. Looking at plans, so here we want to know what plans are in place, who did you work with doing these plans. So the majority of NPHIs had a formal framework in place. The majority of them, 75%, did update this plan since COVID-19. As Andrew also mentioned, that we learned a lot during COVID-19. So a lot of the NPHIs were actually using those lessons learned to update their plans. The majority of the respondents indicated that they did work with other departments, agencies, or organizations in producing this plan. But then looking at the contribution at a regional or international level, only 47% of NPHIs reported that they actually contributed to these plans. 24% said they contributed for certain hazards, and then 9% contributed, did not contribute at all. So now we're going to, so that was the demographics of our respondents. Now quickly we're going to start looking at the GHEC domains, starting with our public health workforce and our emergency workforce. So workforce planning, looking at the plans in place, 54%, so just slightly more than half indicated that they did have a plan in place. The majority indicated that it was developed or updated in the past 3 years. If we look at who is responsible for the planning and the needs assessment, then mostly the Ministry of Health, then followed by the NPHI, were responsible for planning and needs assessment of health workforce. And again, both the Ministry of Health and the NPHI will provide staff, and of course there was a higher response rate for national emergencies. When we asked about what are the key workforce challenges that NPHIs experience, this was mostly related to funding, training, workforce planning, although a lot said that plans were in place, as well as retention of staff. Now we're going to look at the surge capacities. So of course we want to be able to surge if we do encounter a health emergency. So if we have a look at our national health emergencies, 75% of the NPHIs did deploy staff for a national workforce emergency since 2014. The workforce that were deployed was very much related to the mandate and the expertise of the NPHI. So the type of workforce that they would deploy generally are epidemiological and public health response, data team, public health rapid response teams. Again, we see surveillance and lab come out strongly. Remember, that's what I spoke about earlier as well in one of the slides, and public health technical experts. When receiving staff from regional or international organizations, 36% of NPHIs received staff. This was mostly in the lower income group countries, Afro and EMRO. And again, we're seeing the same type of workforce, EPI, lab, public health rapid response teams. But now we also see that they did receive a lot of research and knowledge management staff to come and support. So although we had small sample size for challenges with integrating external staff, because only 36% of the NPHIs indicated that they received staff. Some of the challenges that were identified is really the external staff understanding the processes in that specific organizations, the remit, the responsibilities as well. The orientation and management of the external staff was a challenge for the NPHIs, and also language barriers, getting to know the cultural norms and familiarity with the organization and the country as well. When we asked about challenges for a search capacity at a national level, still the majority of challenges were the logistics required to deploy staff, lack of staff to deploy. Remember, I mentioned that the majority of NPHIs were actually quite small, with less than 500. There were challenges with rapid recruitment, as well as a lack of plans or protocols for the deployment of staff. If NPHIs required a search response, the NPHIs did have 66% indicated that they had existing rapid response teams that could be deployed. Then 64% indicated they would get non-NPHI staff, but staff working in the public health sector for their search response. And then also they would do some temporary recruitment of staff or contractors to help. Now we're quickly going to look at the regional and international health emergencies. Again, the type of the emergency NPHIs will respond to follows their expertise, their mandates, infectious diseases, environmental hazards, as well as biological hazards. Just about half of the NPHIs did deploy since 2014, where we see larger NPHIs having more deployment rates because they probably have more staff to be able to deploy. So the workforce that are being deployed is similar as for national emergencies. Again, we're seeing the epidemiology, public health rapid response teams, and the surveillance staff coming out strongly with the majority of NPHIs. And interestingly, for pre-deployment training, only 75% of the NPHIs gave training on health and safety. Cultural awareness and orientation was done by 68%. And I'm highlighting that, remember, one of the integration challenges was actually for staff to integrate in their receiving organization, and personal security, 61% of the NPHIs. So for the deployment mechanisms, that 50% of NPHIs that I was talking about, the majority of them actually deployed using so 50% of them. Then also 46% of these NPHIs were using other international organizations such as the European CDC and Africa CDC. And here we also see that 36% of NPHIs actually directly deployed to another country on an ad hoc basis. Search challenges experienced when responding to regional and international emergencies, pretty much the same as for a national search. Again, logistical challenges, lack of a plan or protocol, challenges with the coordination, and also lack of staff. We also did have some differences within the NPHIs across the income levels. So mostly LICs had a lack of deployment plan and budget, and our high-income countries really struggled with the coordination of the deployments at an international level. So we asked our NPHIs, so what are the top priority areas for improving surge capacity? So they said their top priorities are resources, so mostly funding, monetary, which we said was a challenge, workforce, both the capacity and the level of expertise, emergency planning protocols, coordination, and communication as well. Quickly, we're going to go into that connected leaders domain of GEC at the moment. So most of the NPHIs did have a high-level NPHI lead for health emergencies, 84%. And if we have a look at who are the key partners for NPHIs, we see it's mostly Ministry of Health, and that's across all three levels of emergencies. Then we see other government departments also across for national regional emergencies. And when we get to regional and international emergencies, of course, then we start seeing the regional organizations and the international organizations being partners. For collaborations, most of the NPHIs, so just over half of them, had agreements with other NPHIs and international organizations, but the nature of the collaboration varies very much. The majority of them shared health intelligence, lab samples, we know was really important, and testing for COVID, testing capacity, or staff support. When we asked about how do you actually collaborate with other NPHIs, they were saying that across all stages of a health emergency, they would meet with other NPHI leads. Then also we would collaborate before and during, and then but simulation exercises before health emergencies done for 69%. And after a health emergency, we have about 67% that will do shared lessons with the NPHIs. When asking who would an NPHI contact, this would mostly be WHO for alerting, information sharing, to request assistance. Again, then we see our continental organization. Other NPHIs will come in, IANPHI for assistance as well. And then, as I mentioned, the international organizations as well. When the NPHI will make contact also differed between our NPHIs, but the majority of them will actually contact the organization when a health emergency has been declared and when additional support is required. And NPHIs in our Euro and AMRO countries were more likely to make contact earlier. If we wanted support, the three most requested support that we would request for, again, across all levels, was technical expertise, again, financial support funding coming in, as well as professional public health support. We did see that there is not a lot of protocols on who to contact when we are contacting these organizations, but we do have more protocols for emergency at a national level, so for professional public health support, technical expertise, as well as the drills. So looking at simulations and lessons learned, most NPHIs did indicate that they are involved in simulations with national partners and within their NPHI, looking at training, sharing of best practice, and research and development. 54% of the NPHIs undertook a lesson learned activity. Half of them said that they always involve other organizations in this. And just over half indicated that recommendations will always be implemented. So really, that was a big mouthful. There's a really comprehensive report as well that you can go and read. But the key findings are that NPHIs differ by regions, by income groups, and this is really driven by their mandate. Not all of the NPHIs had a legally mandated role in health emergencies, so there is a need to clarify and formalize the role of NPHIs, and this should be supported by legislation. NPHIs were mostly focused on infectious diseases, environmental and biological hazards, less so involved in actually mobilizing field teams and One Health functions. There is a need for investment in public health workforce. So this is both for the routine functions as well as looking at a surge capacity. So this includes identification of the skills that's needed and multi-sectoral teams. So we need to strengthen our search protocols, our coordination mechanisms. We did see that that was a big challenge. We need to strengthen the networks and collaborations within the country, regionally, and internationally. And NPHIs are very well suited to act as bridge connectors to be able to create this collaboration and dialogue. And also NPHIs has to be involved in these regional international plans and protocols, and also for NPHIs to share their best practices through regular engagement. So, and that's everything from me. Thank you, Raphael and team.
Thank you so much, Janine, for presenting that comprehensive overview of some of our, quantitative data that we collated from the survey. I think it's really important for us, and I think all of us recognize that each of the responsibilities and roles that NPHIs have are very much contextual to the size of the country, to the governance within that country, to the mandates and authorities that have been set by the governments and their reporting structures. So we found a lot of the variance because of those different mandates. However, that doesn't mean that everything's perfect. So there are still, gaps and constraints which we identified through the survey. And later on, I'll talk a bit more about the phase 2 work that's going to be initiated. But I would like to pass on to Rosita, who will just give you a comprehensive overview on the second part of the work that Andrew mentioned, which was the interviews with the key leaders. Rosita, over to you.
Thank you so much, Sadaf. And I'm delighted to see that there's so many who have joined this webinar this afternoon or morning or evening, wherever you might be. So let us take a closer look at the findings from the Connected Leaders interviews. Next slide, please. First of all, in addition to the presented survey that Janine presented, we undertook key informant interviews. They were held with a selection of senior leaders of 15 NPHIs. These NPHIs represented different World Bank income groups and all the WHO regions, and also they represented different types of NPHIs. They were based in various types of countries, centralized, decentralized countries, in a federated state, at subnational level, in a federation, as well as a supranational NPHI, which is responsible for several countries. Next slide, please. And the objectives of the key informant interviews, well, mainly it gives us a chance to explore the concept of connected leadership for all hazard emergencies from a subnational, national, regional, and international perspective. And it also gave us a chance to discuss enablers and barriers to NPHIs in responding to national, regional, and international health emergencies. So this was an opportunity for us to verify some of the results that came out of the survey. Next slide, please. And these are basically the key themes that were emerging from the interviews: the legal and political mandates, mechanisms and processes, workforce and resources, systems and structures, and of course, a lot about connected leadership, but also quite a lot about specific country contexts. So we will look at those in much closer now. Next slide, please. The legal and political mandates, Janine has already mentioned that those are imperative, very important, as they dictate the permissions, remit, and autonomy that an NPHI has to operate in health emergencies. And as we know, these remits may be split between various organizations. It's not only the NPHI, and there's considerable variability in the legal mandate, as Janine mentioned. We also found that political support is important, as it appeared to be correlated with the degree of resourcing for the NPHI and the remit that it has. So our conclusion is that the political context is both an enabler or a constraint on NPHI's activities in health emergencies and in global health engagement. Next slide, please. NPHI leaders mentioned several issues that were related to mechanisms and processes. The need for clear mechanisms for mobilizing surge capacity, even from their own staff, was mentioned. And there's a need for coordination of surge responses. There are, as you know, multiple routes from NPHI to NPHI, ministry to ministry, government to government, WHO, various collaboration networks, GORN. These were all mentioned previously by Janine. And we know that some countries have mechanisms in place with bilateral agreements or, for instance, the EU Health Task Force. Leaders mentioned various issues related to deploying a response, such as late engagement or legislative requirements. But they all said that we need to be prepared and have tested logistics, basically. Some countries or some NPHIs require governmental approval when it comes to international deployments, and they said that such processes may take some time. Next slide, please. So when it comes to workforce and resources, there were a number of issues that were mentioned. Resource mobilization was seen as a major barrier or could be also a major enabler. They said sometimes they need to apply for funds from Ministry of Finance, and such processes may delay the whole process of the mobilization. Very many were depending on donors and development partners for resources. And overall in the world, we see shrinking NPHI budgets at the moment. And also some resources that are needed are found outside the NPHI. So sustained and predictable funding is imperative. And this is a quote from one of the NPHI leaders. In a crisis, there will be funding. The funds become available when the house is on fire. The challenge is to have funds before it is aflame. That is very telling for the situation for many NPHIs. Next slide, please. There were also issues related to capacity and surge capacity gaps, difficulty to deploy staff because of numbers or the experience or the right staffing or skills mix. There was a need for training and capacity building, training on contextual awareness, particularly for international deployments. So these findings all sort of confirmed the survey findings. They also mentioned that staff retention might be a problem sometimes because it is an international workforce. They can move on if they find greener pastures. Leaders emphasize that knowledge, data, and information sharing is crucial in emergencies, and they need to be sustained in peacetime between emergencies. And information and knowledge exchanged and learning within and between countries could be facilitated, for instance, through simulation exercises. Next slide, please. So systems and structures are important, of course, and the ability of the public health system to respond to a health emergency was noted to be contingent on the health infrastructure in place. And this figure illustrates the pathway from surveillance to public health response and the different partner roles that are involved. It is clear that there are several agencies and several sectors that might be needed to be involved in a public health response. Next slide, please. So many NPHI leaders emphasize that public health emergency responses is not a single agency domain, but it is a multi-sectoral and multi-agency endeavor involving multiple ministries, agencies, NGOs, communities, development partners, etc. Hence requiring multi-sectoral and multi-agency collaboration, coordination at various levels, subnational, national, regional, and international levels. And such capacities need to be built in peacetime before an emergency happens. Next slide, please. We had in-depth discussions with NPHI leaders about connected leadership and what it actually means to them and why it is important. So they said that we need to have collaborative leadership. We need bridge connectors who can build bridges within NPHIs and outside the sectors. And they also emphasized that when it comes to international collaborations, it was weighted towards regional collaboration because our neighbors' problems are our problems and our problems are our neighbors' problems. So there is perceived a mutual benefit and reciprocity between NPHIs, mainly within their own region. And therefore, we need to have good pre-crisis relationships, and these are seen as an enabler for effective emergency responses. Next slide, please. And we must remember that the context and the environments in which NPHIs operate are highly diverse. The survey really showed that. The interviews also talked about the administrative culture in your society that influence the context a lot. And therefore, there is a need for flexible guidance and frameworks to be translated into local solutions so that they can fit the local context. Next slide, please. And finally, we do have some conclusions and recommendations. The collaborative connected leadership is key in health emergency preparedness and responses. We found from the interviews that connected leadership is a leadership approach that emphasizes collaboration, communication, coordination, and relationship building across various sectors, organizations, agencies, communities to effectively manage and respond to various crises. And therefore, there's a need for connected leaders network that need to be strengthened to create a network of networks that can operate according to country context at all levels and across sectors. And NPHI must be empowered as national and regional bridge builders that can translate global frameworks into context-specific actions. Thank you. Next one. Thank you so much.
Okay, thank you very much, Rosita and Janine for both really comprehensively presenting the findings from both those elements of the study. So really, at the end of this, it means, so what? What does this mean? What are we going to do about this? As part of the report, we also produced a call for action. And what we considered, and this was at the beginning of the piece that we did, this project that we did, was that we're not really talking primarily about infectious diseases outbreaks, where what the approach that we want to take is an all hazards health emergency approach, because national public health institutes play a role in whether it's a secondary impact or it's a primary outbreak that they have to deal with. And so that all depends on lots of elements to do with how strong the surveillance system is, how strong are the collaborations, how strong is are the networks from national, subnational to community level. So we developed a call for action as part of the report that focused on 4 key elements from a National Public Health Institute perspective. The first one was around legal and political mandates of national public health institutes and how important they were. And where do these actually sit? Because we have to have a whole system approach to health emergencies. It's not just that NPHIs working in isolation. They have to work across sectors. They have to work across agencies, institutions, and organizations. But what is important is the legal mandate that has been set by the government to them and what their responsibility is within that. The second then, of course, is the resourcing and the workforce, and recognizing that depending on the different structures of NPHIs, the workforce and the technical expertise may not neatly sit under the National Public Health Institute. They might be somewhere else where they have to pull them in, or they have to collaborate or work in a kind of interconnected relationship. And so the NPHI becomes also a bridge connector across those expertise and bringing that expertise together, whether that's strategic, operational, technical, whatever that mandate or that role and responsibility of that National Public Health Institute is. The third is, of course, the mechanisms and the systems in which the NPHI works in, and the collaborations that they have to form. So there's a theme that goes in, which is really across this connected leadership piece, which is really underpinning all of this. And then the fourth is around leadership and global engagement. Again, it's not just NPHIs working in isolation. They have to work across a multi-sectoral approach, but they also have to work with their regional and global partners as well. So within the call for action, we took those four elements and then we said, okay, what exactly do we think the roles are of those national public health institutes, taking the findings from the survey and from the interviews, but also who is responsible, who leads on this? Is it the NPHI? Is it the Ministry of Health? Does the NPHI have a primary role in this, or are they interdependent on other agencies, organizations, and institutes to make them successful? So that was the call for action. So our phase 2 of this work is to work with a group of national public health institutes, and we've been very lucky to have a group of 10 NPHIs who are going to be engaged in this piece of work moving forward, with representation from East Asia, Southeast Asia, Africa, South Asia, and the Middle East. We are hoping to identify a couple of more countries, perhaps from Latin America and Caribbean, just to make sure that we have proper geographical representation. But we're going to be looking at 2 areas. And the implementation of that is around the question of how do national public health institutes identify the technical expertise and the operational expertise that it requires during a health emergency well in advance of even the preparation stage. So it's part of norms and normative practice of an NPHI, that they can then surge within a coordinated rapid response mechanism during a health emergency. And the second area of work we wanted to look at is that how does the connected leadership piece work? And in terms of that, how would that operate within a cross-border alliance between nations? And geographically, if you have the closeness of different countries, then how would you easily work across borders with neighboring countries during a health emergency? So this is a co-developed, we don't have the answers because we purely want this to be a co-developed, co-designed piece of work with those NPHIs. We don't know what the approach is going to come out with, whether it's going to be a tool or whether it's going to be something that can be operationally absorbed within the organization. We want to make sure that we engage with HR, finance, procurement, all those really important functions within a National Public Health Institute that make these happen and can accelerate and act as catalysts during a health emergency to support this. And so with those 10 countries, we will be co-designing this. We've carefully chosen those countries based on the different health emergencies that they face within or have faced within their countries. So not just infectious diseases, but it might be flooding, earthquakes, etc., different kind of health emergencies, because we want to look at different modeling and different scenarios as well. We will then do this piece of work over a period of 6 months, and we will also have a consultation as part of our IANPHI annual meeting in Dubai, following which we want to undertake or support a simulation exercise in a couple of countries to see how effective is that approach. And we hope that that model or that tool, whatever will be the outcome of that will be something that National Public Health Institutes can use and adapt and adopt according to their country context and the model of National Public Health Institutes they have. So more to come, obviously, on that as we develop this piece of work. If anybody is interested in learning more or participating, please reach out to us. We'd be very happy to hear from you. We want to hear about current practices as well that National Public Health Institutes currently have that facilitate and help them with that surge mechanism in terms of national, subnational technical expertise or public health workforce that they require during a health emergency. So what I'm going to do now is I'm going to pass the mic as such to Professor Tahmina Shireen, who will be providing her reflections on this work and also just giving a perspective from Bangladesh National Public Health Institute. Thank you, Professor Shireen, over to you.
Shall I share from my end or?
Raphael?
I can share the PowerPoint for you. Can you see it?
No, we just see you, and we see the NPHI perspectives slide.
Let Professor Shireen share then. I think you can go ahead and let me know if you have any issues. I'll share your presentation for you.
Tahmina, if you can share your presentation, that would probably be better.
Okay, thank you.
Thank you very much.
So, can you see the slide?
Yes, we can.
Yes, we can.
Thank you. Good morning, good afternoon, and good evening. First of all, I would like to thank the IANPHI for inviting me and give me the opportunity to describe the role of National Public Health Institute in health emergency confirmation. Actually, I'm working in an institute which is known as Institute of Epidemiology, Disease Control and Research. This is the National Public Health Institute in Bangladesh. We mostly deal with we have few objectives, and we are mandated for the disease surveillance in the country. We have indicator-based as well as event-based surveillance in the country. We do outbreak investigation and response, and we also provide trainings in 3 tiers of field epidemiology training program, FAM training, and also we provide training for the rapid response team. Besides this, our institute is the focal institute for IHR and also National Influenza Center. And we have BSL-2 laboratory, microbiology, virology. We have the provision for molecular detection, NGS platform, and serology, and cell culture, and microbiology. Microbial detection of microbial pathogens. So a few of our laboratories are also the national reference laboratory, like for the different pathogens like influenza, Nipah virus, and SARS-CoV-2. And our microbiology lab is also designated as reference laboratory for AMR in the country. And besides this, we also do some sort of research. So I have already mentioned that we have the indicator-based surveillance. So if there is any, when there is any public health emergency, we got notification through the routine indicator-based surveillance as well as from the event-based surveillance. So when we get the notification, actually our public health emergency operations center, they receive those notifications. So after getting the notification, they verify the events, and if it is okay, then our rapid response team move to that particular place within 24 hours. And we have 3 tiers of rapid response team. One is the National Rapid Response Team, the team who belongs to IDCR, in our institute. Then down that we have a district rapid response team. So if there is any event that occur in the district, so we also bring those people in our team to investigate and respond to that particular outbreak. And down that we have URRT, that is Upazila Rapid Response Team. Actually, this is the sub-district rapid response team. So we have the rapid response team in different layers. And if there is any outbreak with zoonotic origin, or in that case, there is multi-sectoral involvement. We actually investigate those outbreaks in One Health approach, and we bring the people from. We make a comprehensive team in a combination of the people from animal health, from wildlife, and we also keep the anthropologists there. So like in Nipah virus infection outbreak, we put the people from wildlife. If there is a anthrax outbreak, we always keep the people from animal health, and always we keep the anthropologists in case of the outbreak with zoonotic origin to look at the behavioral pattern of the community, their perception, to look at the total scenario of the community. So our PHUC actually it remains in 3 modes. In different times. During the watch mode, they usually look at the monitor the media. They also get the information through hotline, and also look at the surveillance data and analyze the surveillance data. If there is any event then or incident verification, then it goes to the PHUC goes to alert mode, where they analyze the demographic epidemiological data and collect the data and do the analysis. And if there is any notification and it is a real notification, then they move to the response mode and mobilize the rapid response team and brief the incidents management team regarding the outbreak. And when they remain in the field, they always keep in touch with our IEDCR, and they collect the sample. They send the sample for send the sample from the cases as well as from the environment to look at the root cause of the outbreak. And after completing the outbreak, we actually report with the recommendation. So So regarding the public health emergency confirmation, I have already mentioned that we get the information through different sources, like in formal reporting from the field or the subnational level. We get the information by analyzing the surveillance data as well as by media monitoring, and we also get this information through hotline. So whatever it is, when we get any signal, we do the trials, we verify the potential threats, and if it is okay, then we start our outbreak investigation. And during that time, I have already mentioned that we collect the samples from the cases as well as from the environment, and we do the laboratory testing. We have the facility for molecular detection as well as the bacterial. We have the facilities for isolation of bacterial pathogen and characterization of the bacterial pathogen, and we also do the sequencing when it is required. And simultaneously, we also do the risk assessment and analysis and provide policy advice to trigger national response. When we complete the outbreak investigation, and we prepare the outbreak investigation report, and for the regular outbreak, we used to share the report with the recommendation to the local authority for further steps, and also share our report with the Director General of Health Services. If it is in a large scale, in that case, we need to communicate with the Ministry of Health through Director General of Health Services, and also with the other relevant ministry if it is required. And in case if the outbreak investigation is of notifiable disease, because recently we already investigated H5N1 cases in the human. So in that case, as the IHR Focal Institute, we report to IHR Focal Point at DGHS, and IHR Focal Point then shared the information with WHO country office and to CRO, our regional WHO office. And if there is any cross-border issue, in that case, we reach out to the Ministry of Foreign Affairs, and in that case, we need their involvement for diplomatic dialogues with a neighboring country. And simultaneously, during this, sometimes after the outbreak, we do the after-action review. If it is a large-scale outbreak, we do inter-action review. We disseminate this information to relevant stakeholders, as well as sometimes we arrange the media orientation. I have already mentioned, if there is any outbreak of zoonotic origin, we do the outbreak investigation in One Health approach, and that's why we have an existing One Health operation system to hold all the stakeholders of, all the relevant ministry. We have 3 tiers of committee. At the top, there is interministerial committee, where the secretaries of different ministries, they are the member of that committee. And down there is a technical advisory committee, where the members are the Director General of different directorates. Actually, right at this moment, we are in the One Health. During the one, if we talk about the One Health, the Ministry of Health, Ministry of Livestock and Fisheries, Ministry of Wildlife, they are the stakeholders, and at the bottom there is another committee, that is coordination committee, where the director of different departments, they are the member. And right at this moment, the Ministry of Health is leading the One Health activity in Bangladesh. So One Health Secretariat is situated at IDCR, and director of IDCR is the chair of One Health Secretariat. And we have been started our One Health journey since 2008, and we are practicing this One Health activities and we are trying to practice this One Health approach in different outbreaks. And here we can see some books. These are the handbook on Public Health Emergency Operations Center, and we have a guideline for Nipah management and prevention. And here you can see several risk communication and community some leaflets for risk communication and community engage, which is in native language for the community. During the outbreak, we used to supply these leaflet to the community and as well as the local health managers and other stakeholders for risk communication and community engagement. That's all from my side. Thanks. Thanks for patience hearing.
Thank you very much, Dr. Tahmina. Really appreciate your presentation. It's really good to hear from a country perspective around your organization and how you support and the roles and responsibilities that you have and the key role that your organization plays in terms of health emergencies as well. I would like to move on to Professor Amar Ikram. Amar, you are the Vice President of IANPHI. You also were the ex-director of the National Institute for Health Pakistan as well. So you have, been through quite a few health emergencies yourself in a leadership role. But I'm very curious to hear your reflections, not only on this piece of work, but how does this fit from an IANPHI perspective? And where do you think, we really need to focus on in terms of not only from a global perspective, but also regional and individual NPHI perspective? Thank you.
Thank you very much, Sadaf, and greeting to all the colleagues and participants across the IANPHI network. It is a privilege to join this panel and contribute to the discussion. I think we have had some wonderful presentations, and based upon that, the survey and the Connected Leaders interview confirm what many of us have experienced firsthand already. The legal and the political mandate you have heard about that defines what an NPI can do in the crisis. Without clear authority and political backing, response efforts are constrained always. In Pakistan, quoting an example, we saw how alignment with the highest political level during COVID pandemic helped rapid mobilization and resources along with policy actions. The number two aspect, the surge in capacity and resources remain the Achilles heel. The report notes that the funding often flows only when the house is on fire. And this is the most unfortunate part. This is unsustainable in any case, and NPHIs must secure predictable preparedness funding to avoid being perpetually reactive. The third aspect, workforce and retention, are critical gaps. We cannot build emergency corps overnight. Sustained investment, again, like the previous in training, especially at the subnational level, is extremely essential. Connected leadership, I think I'm already fascinated by this terminology, and I think we need to propagate it much more than it is right now. Has emerged as a unifying theme. That's also very, very important, and trust-based networks and partnerships truly enable effective responses. Now, building the networks of trust nationally, regionally, and internationally is vital in any crisis. In Pakistan, during the pandemic, again, close collaboration with WHO, other donors and partners, international bodies, INGOs and NGOs, and the neighboring NPHIs really demonstrated how shared expertise can accelerate the response. Now, I strongly endorse the call for action as has been outlined today. Talking in terms of institutionalized mandates for health emergencies within NPHI, particularly backed by the legal framework, predictive preparedness funding, secure core funding for preparedness, so we are not dependent on emergency appeals, strengthen human capital, creating flexible emergency corps with clear deployment mechanism. We need to continuously invest in human capital and surge capacity. And already pointed out in the survey, there are certain in which it comes under the NPHI, the human resource, and others. So in any case, it is the bridging role in case the human resource doesn't come directly under the NPHIs. And I would also say that invest in the system and logistics that are tested before crisis, not during, as it is always said, you cannot prepare during a crisis. You have to be ready before it. And I think pandemic has given us a great example. And coming out of that challenge, we do have multiple opportunities that we need to build upon. And finally, promote connected leadership across borders and sectors where NPHIs as bridge builders across the sectors, translating global framework into local action. I would like to lay a little bit of my strategic perspective for NPHIs as far as the global bodies are concerned. We all aware that WHO remains the normative and convening authority. But the pandemic showed that NPHIs cannot be implementers of global recommendation. They must be partners in shaping those recommendations. GHAC would be meaningful as it solidifies and becomes much more robust. Pandemic fund through the World Bank is yet another opportunity, and so many low-income and low-middle-income countries are already getting this funding. So this is the time to utilize this funding in solidifying at the national level, at the subnational level, and then moving on to the regional level. NPHIs should contribute data, insights, and innovations into WHO processes, ensuring guidance reflects realities on the ground. Now, IHR is one great example where most of the countries are already signatory and providing the data, and it becomes much more meaningful. And I think during the pandemic, it worked very well. Then we have other international organizations and networks that are critical connectors. Bodies like TEFINET, that is responsible for the FETP's production, other bodies like GOAN, Gavi, FINE, CEPI, and there's a long list, innumerable number of bodies. Wider mandate bodies like ECDC, US CDC, Gulf CDC, and PAHO. They are effectively working within the regions. But I always feel that in our region, we don't have a regional body as yet beyond the Gulf CDC on this side where that can be integrated for future such responsibilities. I must appreciate the role of AMPNet over here, that it has taken beyond FETPs and coming up as a body, which is helping the EMRO region, again, very comprehensively. The NPHIs must not work in silos, but position themselves as the central nodes within these networks. For example, TEFINET, AMPNet, leverage field epidemiology training, and for sustained surge workforce. And as you all know, that FETPs worked very well during the pandemic, and I think they need to be strengthened further. And that's how the concept of GFAP also evolved. Similarly, GOAN enable rapid deployment through clear pathways for NPHI-led surge support. And I think the outcome of these two surveys and studies would become much more meaningful for these bodies for the implementation as well. Not only for them, but definitely for the countries, moving on to the regionality, moving on to the global level. As far as Global Fund, Gavi, and other bodies are concerned, they need to align the national system with the global innovation, vaccine, diagnostics, and delivery. And that's why you heard the beautiful, again, terminology of network of networks. The opportunity is there, wherein PHIs are both beneficiaries as well as contributors. Coming down to the health emergencies, emergencies are no longer rare events. They are recurrent. We must realize that pandemics, climate-related shocks, displacement, conflicts, and ever-rising antimicrobial resistance. NPHIs must shift from being reactive responder to becoming permanent preparedness platform, integrating surveillance, laboratory systems, risk communication, and workforce pipelines. And you just heard a beautiful example of Bangladesh, how they are coping up with this strategy. Now, building trust with communities and the political leader is as critical as the technical expertise. I can throw reflections on the future, looking ahead. I would like to emphasize on three things. The regional capacity building must complement national efforts. The Eastern Mediterranean region, for instance, has shared threat that demand regional surge and solidarity mechanism. Knowledge exchange should be constant, not episodic. Simulation exercises, joint trainings, and peer-to-peer exchanging are the tools that keep our networks alive in the peacetime. And definitely looking toward the phase 2, as Sadaf already pointed it out, what would be the outcome, I think, would again, in form of any tool or whatever mechanism, would be meaningful for, again, the countries and at the regional level. The NPHI is a trusted advisor in emergencies, political leaders look for credible, evidence-based guidance. Strengthening NPHIs ensures that government, donors, and community hears a clear, authoritative voice grounded in science. And please remember, this is grounded in science. Is something very, very important, ensuring that the governments make decisions anchored in evidence. And just to conclude, this report gives us evidence, but our task is to act. And the time is now. And time always moves out the hand, so we have to act rapidly. This report underscores the urgency of empowering NPHIs as cornerstone of national and global health security. The finding, recommendation, and call for action must not remain on the paper. They should be translated into commitments by governments, donors, and NPHIs in particular for the community, for the regional level, for the global level, and all comes one. As Vice President of IANPHI, I'm confident that together we can advance a future where NPHIs are fully enabled to protect the populations in all times of crisis and beyond. Once again, thank you so much. Back to you, Sadaf.
Thank you. That was wonderful, Amar. And I think that really neatly brought together all the different threads and where IANPHI and our National Public Health Institute family sits in terms of health emergency ecosystem from both international and national level. We're going to move on to the question and answers. I'm very conscious of the time as well. I don't see any questions in the chat, but if anybody would like to ask a question, so you can unmute yourself, just raise your hand and I will call your name out, and then please feel free to ask a question or even make a comment as well. And from whatever you've heard, if you have any, reflections yourself, then we would be very happy to hear them. Okay, I'm going to give you a couple of minutes to think about it, and I'm just going to make a reflection myself from the work that we've done here. Is we all recognize that those levers and enablers, whether they sit outside of national public health institutes that provide the infrastructure that national public health institutes need to prepare and respond to health emergencies. But what has always, I think as IANPHI, as an advocate for national public health institutes, it's always a challenge that how do we get the ear of those people who enable national public health institutes to be successful? And I think, when we have meetings like this or we do studies like this, it's NPHI to NPHI. Even when we have meetings where it might be with the WHO, the technical experts are usually from the National Public Health Institute. So we all speak the same language, we all agree the same issues, but actually the solutions don't lie within the National Public Health Institute. It lies with the Ministry of Finance, the Ministry of Health, it lies with the donors. So how can we create a mechanism or engage more widely in these conversations, inviting those real critical stakeholders into dialogue so that, we have an ongoing process of enabling national public health institutes' voices, collective voices, to be heard in the right space at the right time. I think that's one of the challenges that I have seen for national public health institutes in accelerating or acting as a catalyst to get the kind of resources that are required for them. And I know, Amar, you spoke a bit about, the pandemic fund. And the call for action we've seen in the third round of the pandemic fund, the phase 2, recognizes strengthening national public health institutes as one of those key components where we are linked to regional entities providing that support to NPHI. So that's one step forward, but there are many, many other areas and many other stakeholders that need to be actively engaged with us. So I don't know whether you have any views about that. Andrew, would you like to just comment on that?
Thanks, Sadaf. I think that's a very pertinent observation. I think for many of us from NPHIs, We are clinicians, we are epidemiologists, we are scientists by background. So we're often far more comfortable in the technical arts, so to speak, the technical science of the work that we do. But operating in that political environment, that therein lies the challenge. Having that political sway and influence. So how effective we are as NPHIs in mobilizing the response, or as Amir was saying, getting that alignment with national, strategic, and policy goals at the government level. Operating in that political space, that's often the challenge, isn't it? And it's not easy to write a rule book as to how NPHIs do that.
Interesting. No, I agree with you. Amar, is there anything you would like to add?
Yeah, thank you so much, Sadaf, again. I think that's a very critical area. The low-income countries and low-middle income definitely, unfortunately, always get bogged down because of the sustenance of effort. The donors and partners definitely do their best in starting, initiating the process, and again moving on. But once they leave, then the institutes or that system struggles. Now, considering I think pandemic grant from the World Bank, that's a very, very key area. And if you see the transformation, and I think it's been learning from the World Bank side as well. They started off with the low-income countries, moving on to low and middle-income countries. Then they move on to a consortia of countries. And finally, in the third, they remember adding the terminology of entity, and that's how so many things start putting together. So this in turn translate into, again, what we have been talking about, network of networks. And I think that's a very key area that we normally talk of those so many C's, that collaboration, cooperation, coordination, and so many other C's we keep adding. But how it's to move together, I think that can, and that in turn translates into your connected leadership. And that's, I think, very, very important. Back to you. Thank you.
Thank you very much. I can't see anybody's hands up, so I'm going to ask another question of Tamina, just to give another opportunity if somebody wants to make a comment. Tamina, could you tell me a bit more about the cross-border relationship in terms of sharing intelligence? What areas do you see NPHIs facing in terms of challenges that they might have? Is it NPHI to NPHI? Is it government to government? Is it intersectoral? Where do you think some of that focus might be for this piece of work, especially when we're talking about cross-border strengthening?
Thank you. Actually, you see, it's not the issue between the MPIs and NPIs because it's sort of administrative issue. In that case, it's not within the Ministry of Health as well. So it's belong to Ministry of Foreign Affairs. And in that case, I mean, we cannot communicate with the technical person. We cannot communicate with our the public health specialist on other country. So we have to go through those things. But during the COVID pandemic, this was practiced to some extent. When there was upsurge of the infection in the neighboring country, we with the support from our Ministry of Foreign Affairs, we could strengthen the border area because it's a porous border between the two countries. So when the people used to come to Bangladesh, in that case, there was a checkpoint and there was a provision for the quarantine for 14 days. So this sort of activity, in that case, we could practice. And in some cases, when there was the cases were more in several countries, they used to stop the flight from those countries to another country. So this type of practice was during the pandemic. But in the usual cases, I mean, in the regular practice, it's not actually practiced that much. There are some sort of bottlenecks. And now we are talking about, I mean, the WHO is also talking about this type of thing. I mean, especially focusing the zoonotic infection, where it is very usual to get infection from the neighboring countries. So these are on the table. I mean, the people are started talking, and we have also a global health security desk in
our Ministry of Foreign Affairs, they are also working. Maybe we will get more opportunity in the future regarding these issues. Thank you. Back to Sadaf.
Thank you. Thank you so much, Tamina. I think it's worth mentioning that as we're looking at connected leadership, and we've had a wider group discussion around this, is that connected leadership doesn't have to be formal relationships or formal networks. There can also be informal networks and relationships that people build between organizations that then facilitate and help support, responses as well. So that's an area of interest when looking at this work. Is that how does that operate, not only between national organizations to subnational and community level, but also across borders as well. So we'll be diving a bit deeper into understanding this with different types of national public health institutes and their country context. So I don't see any hands up. So I am going to thank you all for joining, being very patient, listening to the presentation. We will be, as we've recorded this presentation, we will be also making this available on the IANPHI website as well. Please have a look at the report. If you have any questions, please email us to the Secretariat. And we hope that in a few months' time, we will be having a similar webinar and presenting to you the outcome of this project or updating you on this project. And if you are attending the IANPHI annual meeting in Dubai, then or online or in person, please participate in the consultation of this work. We would really appreciate it. And if you want to be involved, please contact us. Okay, thank you very much. Thank you to all the speakers. Thank you for attending this webinar. Bye-bye.